remember that you have to recapitulate fast. Which limb is more permeable to water, less to solutes? Which limb is, so you have to know this, the ascending limb, the thick part of the ascending limb. Thin limb is not present. Not present is a wrong word, I think. It is that is in the cortical nephrons, which are shorter ones. Thin limb is not very well expressed. It is the thick part of the ascending limb which is expressed, and the solutes, that means we will consider mostly NaCl. I mean, if we talk of NaCl is passing reabsorption. Reabsorption hoche NaCl. So NaCl reabsorption in the, obviously in the proximal tubule, but in the thick part of the ascending limb. Now there water is not very, that is water permeability or water transport is restricted in the thick part of the ascending limb and the distal part of the early part of the distal tubule. Just concentrate on these, don't concept. We are very short of time. I think tomra bujhte parcho na, you are not understanding, but in a very short time we have to cover whatever is left. I can go, if I had the opportunity, I would go on taking 4 or 5 classes for whatever is left. So just see in the thick ascending limb, and if they had, it can be distributed distal tubule they have written, but in the early part of the distal tubule it is also impermeable to water. So these are called the diluting segments. These are called the diluting segments. Now this, to understand this countercurrent mechanism, you have heard of the countercurrent mechanism at your school level, countercurrent mechanism. Why is it called countercurrent? Because there is the loop of Henle and the flow just reverses in direction at the loop. That is, it is cow. So how the medullary osmolarity is maintained? Medullary hyperosmolarity. That is, osmolarity is maintained, and this, from the exam point of view, this comes as a question. As time is short, I have repeatedly asked the students, see the questions from the previous years. What comes as a question? But first understand, it should be, ideally it should be like this. We should understand the topics and then go to the questions. But time is short for you. Exams have been preponed and all this you know by now. And also in the cortical collecting tubule, inner medullary, just you can see from this chart that absorption of water in the later parts, that is the collecting tubule, inner medullary collecting duct. Inner medullary means, just think of it again. So it is actually like this loop of Henle, and then the early part of the distal tubule, then collecting duct. So some part will be in the cortex, and this is the outer medulla. Cortex, outer medulla, inner medulla. So the part of the tubule, there, so whatever is in the inner medulla, that is called the inner medullary collecting duct. So we have already mentioned the parts, and I repeated that without understanding the anatomy, and side by side goes the Vasa Recta. In case of juxtamedullary, without understanding the anatomy, you will not be able to follow it. When we are discussing the what is actually happening functionally, what is happening. So in those parts, ADH is responsible. Without ADH, water reabsorption is not so much. One question comes like this: discuss about water reabsorption throughout the renal tubule. So mostly it is. So most of it, whatever mostly is in the proximal tubule. So just see this. You can have, just to show you, have to, whatever books you read, it is sufficient to no, these are not. So I have just forgotten the order. See, so water reabsorption 65, mostly 3/4 of it is in the proximal tubule. But you have to, if the question comes like that, why I am asking you to see the questions first and then read the topic, which is not at all ideal. First we should read the topic, but time is short. Not for me only, for you. Not for me only, not for us. This is not about only completion of the syllabus. So you have to read and sit for the exam. So time is short. So again you have to write, if water reabsorption, write about water reabsorption in different parts of the tubule. So then 65-75% is in the proximal convoluted tubule. But what happens thereafter? So thereafter, just note, at least mention this, that thick descending limb and early part of distal tubule are almost impermeable to water, more or less. So it is showing like this, it is 0. It is 0. Double plus, here they have double plus means it is highly permeable. Single plus means it is moderately permeable. So this will help us understand the countercurrent mechanism. Countercurrent mechanism, one is why the name, because the flow reverses at the loop of Henle. This is easy, just countercurrent. Now how does this maintain the hyperosmolarity? So we start from, just to start, it is a dynamic process, just to start. So I should draw it better. This is the, at least in the juxtamedullary nephrons, the thin part of the ascending limb is somewhat appreciable. So thin part, then thick part. What happens in the thick part? These active pumps are working. Okay, this is wrong. This one. So in the thick ascending limb, it is thin ascending limb, thin descending limb. It is not permeable. Permeable means this pointer, I think, is not working. See, thick ascending limb, permeability to NaCl, it is written 0. It is not permeability means simple diffusion, or diffusion is not occurring. That is, passive transport is not occurring. Transport can be active or passive, as you have read in general physiology. Passive transport is not working, but this active NaCl transport is working. So NaCl, first we consider, to understand this mechanism, just suppose hypothetically all throughout this U shape, this loop, all through these limbs, proximal. So to be very, so I should draw this proximal convoluted tubule as well. All through this, if say it is osmotically same, what is the osmolarity of plasma? 290 milliosmoles per liter, 270, 290, take it as 300. So first thing, it is 300 all through. But if NaCl is reabsorbed in the thick part of the ascending limb, this is permeable. So what happens? If NaCl is reabsorbed, osmolarity will be increased in this interstitial space, and this will go down. So that becomes 300, becomes this 300, then becomes 400. So this 300 becomes 200. So hypothetically considering isoosmolar, if we start from the thick acid, that their maximum transport, active transport is occurring, altering the osmolarity inside the tubule as well as inside the plasma. As NaCl is reabsorbed, osmolarity inside the tubule will decrease. Sorry, it will be opposite. It will be 200 here, 400. So decrease, but the gradient of 200. But what happens? As soon as this happens, to explain, we are telling this as soon as. Actually, this is a dynamic process. Through the thin descending limb, water is permeable. So water is going out, water is being reabsorbed, and then it is trying to balance. But as this is happening, this is just, note this, see, 300, 300. So osmolarity, this is actually what it is. ব্যাটারি কমে গেছে, এটা কাজ করছে, পয়েন্টারটা সবসময় কাজ করছে না, কোনো প্রবলেম। This red pointer is not working anyway. See, this is actually, see, note the early part of the distal tubule after the thick ascending limb, okay, not very permeable to water, and these are called the diluting segments. Diluting segment means in the tubule the fluid is diluted. Okay, NaCl is reabsorbed, but water is not being able to enter, so the osmolarity is decreasing. See, in the early part of the distal tubule, it is only 100 milliosmoles per liter. Then it is 200. Then again it becomes 300, 400. We are coming to that. But in that part, that is, these parts are called the diluting segments, because NaCl has gone out, but water is not being able to enter. So this is just a summary, but this is not about the countercurrent. See the countercurrent. So see, permeable to solute, not to water. These are very schematic diagram. This part, This right side আর কিছু এটা নেই না আছে so I just can't point out because this is not working. You can see the small point. So see, this is permeable to solute, not to water. This is permeable to water, not to solute. And this is not an ideal diagram, just schematic. This is same, showing as if it is the same thickness, but descending limb, this is the ascending thick limb. And obviously this is showing NaCl is transported, and that too active transport in the thick ascending limb. In the descending limb, it is permeable to water, but not to solutes. This is the basis of how we understand the countercurrent mechanism. So see what happens. Hypothetically, we consider first everything to be 300 milliosmoles per liter all through. Then it just balances 200. It becomes 200 because NaCl is actively transported. But to balance this hyperosmolar medullary interstitium, water flows out through the descending limb. It cannot flow out through the other parts. That descending limb is most permeable to water. It flows out through the descending limb. Now this is occurring a situation where this is 400, but what is happening? Through the proximal tubule, more and more fluid is coming, which is at 300. So this is the countercurrent. This is flowing. This fluid in the descending limb now is pushed by that isoosmolar fluid which is coming 300. Now this is pushed to the ascending limb. As this goes, now what happens? As this is pushed, more and more NaCl active transport in the thick ascending limb. So these are the steps from a hypothetical situation. All through is considering 300, thick ascending limb transporting NaCl actively, and descending limb permeable to water. These try to balance the hyperosmolar medulla, just hyperosmolar medulla. পুরোটাই 300 ছিল, 300টা ভেতরে 200 হয়ে গেল, বাইরে নয়, বাইরে কথাটা বলা, বাইরে একটা বলার জন্য বললাম, দ্যাট ইজ দ্য মেডালারি ইন্টারস্টিসিয়াম। যেই 400 হলো, সেই 400টাকে কে ব্যালেন্স করছে? ডিসেন্ডিং লিঙ্ক দিয়ে ওয়াটার বেরিয়ে গিয়ে ওটা 400 হওয়ার চেষ্টা করছে। কিন্তু একই সাথে কি হচ্ছে? থ্রু দ্য প্রক্সিমাল স্ট্রেট টিউবিউল মোর অ্যান্ড মোর 300 milliosmol per liter fluid এসে it is driving this fluid now through the loop of Henle. তখনই active NaCl transport. Now whatever was this now এই গ্রেডিয়েন্টটাকে যেখানে 150 ছিল সেখানে 350 করছে। So this is যেখানে 300 ছিল সেখানে 500 করছে। So this is due to the thick ascending limb NaCl active transport. Now as this goes on, after some time, this is called the countercurrent multiplier. As this goes on, after some time, these steps being reported time after time, what happens? Repeated time through sometimes, what happens? This bottom part of the loop, that becomes the most hyperosmolar. So this is how the hyperosmolary medullary interstitium is created from a hypothetical scene. But in the actual body, it is a dynamic process. Maybe in some nephrons these are at a time working more perfectly, and in some nephrons it is working out, but as a sum total of all nephrons, there are 2.5 million nephrons to the two kidneys, if you 1.25 in each kidney. So as a sum total of nephrons, so medullary all these nephrons, so many million nephrons in the kidney, this medullary interstitium hyperosmolarity is maintained. But just to understand this, we are considering a hypothetical situation where everything was 300, now it is going on multi. This is called the countercurrent multiplier. And what is the role? And this countercurrent multiplication and this exchange of the solutes, which is more in the juxtamedullary nephrons, because juxtamedullary nephrons, what is the from the anatomical consideration point of view, what is the peculiarity or what is the structural characteristic? That these have long vessels following the long blood vessels following this loop, this tubule. In case of cortical nephrons, it is just peritubular capillaries that will not be effective in concentrating this urine. So ultimate aim is to, when the kidneys have to conserve water, then urine has to be concentrated when kidneys have to conserve water. And in the what we have seen, Just go to this again. What we have seen in the later parts, in the late part of the distal tubule, cortical collecting tubule, inner medullary collecting duct, permeability to water is only under when ADH is there. That means when ADH is acting, antidiuretic hormone. When antidiuretic hormone is not acting, that water passes out through urine. See, in case of urea also, we will just come to the role of urea in this hyperosmolarity medulla. See, in case of urea also, even in the cortical part of the collecting tubule or the collecting duct, some books will write it as collecting duct, cortical, which is in the cortex part, not even the outer medulla part. There also no permeability to urea, but under the influence of ADH, it is in the permeability urea in the inner medullary collecting duct. So, this urea contributes almost in the inner medullary collecting duct when ADH is working. This also contributes much. If it is 1200, then out of that almost 600 to 700, 500, 600, 700 comes from urea itself. So, urea also contributes to the hyperosmolar medullary interstitium, but only when ADH is acting, and that too in the inner medullary collecting duct. ADH helps to absorb water right from the later parts of the distal tubule, and if ADH is not there, then none of these. Then whatever water will reach the distal tubule, that will go out. So, only when the kidney body signal, the signals is homeostatic signal is there, that ADH has to be secreted, because body needs to conserve water, then only water will be reabsorbed in the later parts of this tubule, that is the distal tubule, cortical collecting tubule and the inner medullary collecting duct. What we said, what is the difference, what is the difference between tubule and duct? That is, tubule, it is considered a part of the single nephron, but whenever it is from few nephrons and forming few nephrons are draining into a common collecting duct, that we are calling duct. Sometimes these terms are overlapping. So, why do we call it the countercurrent multiplier? This part, why do we call it the countercurrent multiplier? Because this is actually gradually, if it is isoosmolar fluid is entering this gradually through this active pump mechanism and permeability, this will gradually increase the fluid, change the fluid osmolarity inside the tubule as well as inside the, it will maintain the hyperosmolar interstitial, hyperosmolar medullary interstitium. This part is the this white part, medullary interstitium. So, do not think that is a space, that is obviously interstitial space, and what is there side by side? There are the Vasa Recta. Now, the Vasa Recta also form a loop or a hairpin like structure. Without that, what would happen? How is blood carried inside the vessels in the capillaries? So, it will draw solutes. Just see this. If the Vasa Recta were not like this, it will just draw solutes. So, solutes will be drawn inside, okay, and the hyperosmolarity medullary interstitium would be washed out, because solutes would be drawn towards inside, water would go out into the interstitium through the blood vessels, because as the tubule, the flow inside the tubule is creating the hyperosmolarity interstitium, but blood just beside it, blood will wash it away the solutes. Where will that solutes go? Will be reabsorbed and go to the return to the body. That hyperosmolarity of the medullary interstitium will not be maintained, and concentrating ability of the urine, or the concentrating ability of not urine, concentrating ability of the kidney would not be possible actually, because just it would be straight, it would just go out. But due to this hairpin like configuration, what happens? In the descending part, what happens? Solutes entering, water reabsorbed. Then this reverses in the ascending part. Hairpin like structure of the Vasa Recta. Thus the Vasa Recta itself cannot, what it cannot do without the tubular flow, what it cannot do, Vasa Recta, flow of blood through the Vasa Recta, even if it is a hairpin like structure, what it cannot do? It cannot create the hyperosmolar medullary interstitium. but without it the hyperosmolar medullary interstitium won't be maintained. Creation by the flow inside the tubules. Creation of the hyperosmolar medullary interstitium, not only NaCl and water, but we'll come to it. Urea has a role. Urea, even urea under the influence of EDH, when it is in the inner medullary correcting duct, when it is reabsorbed, urea also contributes, but alone flow through the tubule could not have maintained the inner medullary interstitium without the Vasa rectus and this structure of the Vasa recta. What is hairpin like configuration? This U-shaped. If it is a straight one, then also this whatever hyperosmolarity would be created in the medullary interstitium, that would be washed out due to if the vessels were just straight. This vessel is also following these loops. That's why these vessels flow through the Vasa recta is called, here it is called the countercurrent exchange mechanism, that is solutes and water are exchanged. It is exchanged and it is maintaining the hyperosmolar medullary interstitium. Just get it because questions come in various forms. Sometimes it comes like short note countercurrent multiplier or countercurrent exchanger or both. I think last year or the year before that it came like countercurrent multiplier and exchanger, countercurrent multiplier and countercurrent exchanger. Or it may come as a say part of a long question or something or short answer type question. How is this hyperosmolar medullary interstitium maintained? How is this maintained? So, how is this maintained? First you have to write how it is formed, this part, first part, and then how maintained by the structure of the, by this arrangement of the Vasa recta. So, you may try to show in one single diagram side by side. If you want, I can give just, okay, 1-2 minutes you can write it down, but don't take pictures. You can write if you want. This is what is explained. So, step 1 is active NaCl reabsorption without water in the thick ascending limb, not thin, thick ascending. In fact, in the juxtaconvoluted nephrons, although thin ascending is well appreciated. Just remember the anatomy. In the cortical nephrons, it is not even well appreciated, but concentrating urine, it is more of a role of the juxtamedullary nephrons because cortical nephrons are actually short and there are no Vasa recta. What are there? Peritubular capillaries. Not straight vessels are not there. Peritubular capillaries are of course there, but that is straight vessels are not there. So, active NaCl reabsorption without water in the thick ascending limb. What is written? Makes the tubular fluid more dilute and the interstitium concentrated. Right? This becomes 200 inside and interstitium becomes 300 to 400. This is the first step. Then fluid in the descending limb equilibrates osmotically with the hyperosmotic medulla. Fluid in the descending limb because it is permeable to water. What is by movement of water out of the tubule through water channels. Okay, we discussed reabsorption last day. Just when you read, just try to read it like that, where in which part of the nephron what is helping, because questions have also come like that discuss about water reabsorption throughout the renal tubule. So, then you have to write in which part it is under the action of ADH, in which part it is by passively by these aquaporins, water channels and all. Channels, simple diffusion, pumps, active. Say, just an example, GLUT protein transporting glucose. We read about glucose absorption in the first part of the proximal, first half of the proximal part of the, this proximal straight tubule, proximal tubule first half. So, sodium and glucose are reabsorbed and on the basal membrane, do you remember that? In the apical membrane, sodium glucose symport is occurring. It is going inside the cell and through the basal membrane, it is going out through GLUT protein. So, GLUT protein it is diffusion, and what type of diffusion? As it is a protein, it is facilitated diffusion, not simple diffusion. And channels, simple diffusion. If it is a protein, facilitated diffusion. Glucose entering along with sodium, it is the energy transporting sodium is also helping to transport glucose. It is an example of what? Active transport, because energy is involved. But what type of active transport? As glucose is going along with, this is an example of secondary active transport. So, this is general physiology discussion. Questions are coming like that. What is say short note, active transport or just secondary active transport. Then you have to write what it is with example. So just when you cover the whole syllabus, then you will get the examples, some parts of general physiology, these examples you will get from the different parts of the syllabus. Autonomic nervous system, I think, I don't know whether it can be discussed separately, I think not, but throughout the physiology classes you will get examples where of the, what is the example of parasympathetic effect, what is the example of sympathetic effect throughout the syllabus. Parasympathetic effect, say when you have read GI physiology, so glands secretion parasympathetic, action of vagus on heart parasympathetic, sympathetic action of heart, it will increase the, okay, we are digressing from our topic. So just to make you this, give you time to write this down. Okay, what is step 3? Step 2, we have told through water channel. Step 3 is this concentrated fluid in the descending limb sets up this counter current. That means reverse direction through the loop of Henle in the ascending limb, where NaCl is also passively, some active plus passive. If we just go back after we write it down, NaCl active plus passive in some part of the ascending limb. Passive means not through, not involving energy, so passive. Further concentrating the medullary interstitium, and water is reabsorbed in the cortical and outer medullary collecting ducts also, but under the action of ADH. Urea concentration marks rigidly, urea then moves passively out of the inner medullary collecting ducts, and there are proteins UT1, UT3, these are the names. Even if you don't remember the names, right, urea is transported in the inner medullary collecting ducts, and this contributes to the increasing interstitial osmolarity. So this is, and urea contributes almost, if it is 1200, it is almost half. Remember, for MCQs, for information as well as, that means for knowledge, MCQs, that highest concentrating ability, that means urine can go, highest osmolarity of urine that can be achieved by human kidneys is 1200 milliosmoles per liter. That is like 4 times the plasma osmolarity, not more than that. More than that, it is not possible. So sometimes it can come as a question, seawater causes dehydration, like this. So to C100, what is the highest concentrating ability of urine? 1200. But if the body has to throw out 1800 milliosmoles of solute, so the extra salt which has gone in, if someone say gets drowned in the sea or just recovers, but he will feel this dehydration will occur because salt water has been ingested and the kidney is trying, say 1800 milliosmoles of solutes are to be, 2000 milliosmoles of solute are to be removed, but highest concentration has to be, can be achieved is 1200. So how much for removing 1800 milliosmoles, how much water has to be removed, how much fluid? It's 1.5 liters, just 1800 by 1200. So 1.5 liters fluid it has to be removed. Then what will occur? Dehydration will occur. So that water has to be removed from the body just to, if the solute concentrating ability if the concentrating ability of kidneys would be more, in some sea, animals residing in sea, their body is adopted like that. Urine concentrating ability is more. Then only with lesser amount of water being excreted, all the solutes are excreted. That is possible, some animals living in the sea. But in humans, it is not adopted like that. Maximum up to 1200 milliosmoles per liter. So last step is Vasa Recta, which I have already told. Vasa Recta has a hairpin-like configuration. So it is in close proximity in the tubule. It has a key role in the maintenance. So without the tubular flow itself, the hyperosmolar medullary interstitium, this hyperosmolarity would not be created at all. So this concentrating ability of the kidneys to form urine would not be possible at all. But even with the tubular flow, but without this arrangement of the Vasa Recta, this hyperosmolar medullary interstitium could not be maintained. So both are, in a way, both are equally important. Both are, the term may be used, say, synergistic, or both are supplementing each other বা complementing each other. So ওটা না থাকলেও টিউবুল না থাকলে তো হলোই না, মেডালারি ইন্টারস্টিশিয়াম হাইপারঅসমোলাটা হলোই না, অ্যান্ড থাকলেও ভাসা রেক্টার এই কনফিগারেশন না থাকলে জাস্ট কর্টিক্যাল নেফ্রনসে কি আছে, পেরিটিউবুলার ক্যাপিলারিজ, বাট দিস স্ট্রাকচার ইজ নট প্রেজেন্ট. সো কর্টিক্যাল নেফ্রনে although they are 80%, 85% of the total number of nephrons, cortical nephrons, they don't have a role in concentrating. So the explain why question can come in various ways. Forming concentrated urine is primarily a role of the juxtamedullary nephrons. Although this has, I don't remember this has come, but questions can be set like this. Or forming concentrated urine is not a primary role for in case of the cortical nephrons. Cortical nephrons are not much of significant in forming or in concentrating urine. The questions can be twisted like this. So I think with this discussion, if you just apply yourself, then you can write all these answers. Just 1 or 2 lines may be different, but you can write all these answers. Just going back again, this is very important, as this is the basis of this. Just see it again. It's like a table, but in your books it will be written which parts of the nephron. Just try to remember this. Which, remember means just study this. Which parts of the nephron are transporting NaCl and water and urea, and how. Okay. Permeability means it is passive. Active means using energy. So let's see, these have sometimes come, see free water, leave free water, but at least the diluting segments of the nephron are the water impermeable segments, the thick ascending limb and the early distal tubule. Okay, thick ascending limbs and early distal tubule. Thick ascending limbs, their NaCl transport is occurring water. That's why they are called the diluting segments. As you can see in this one, here it is 100. Again, this is not, as the pointer is not working, this 100, this part, because it has become dilute, because NaCl has gone out, but water could not be reabsorbed in that part. So that is called the diluting part. AVP is nothing but ADH itself. So in which parts AVP are working and how it is working. Urea, passive reabsorption through UT1, UT3, as well as under the influence of ADH in the inner medullary collecting duct. This is urea transport, but at least remember urea has some role in the creating the hyperosmolar medullary interstitium. Role of urea in creating the hyperosmolar medullary interstitium, and urea concentration, see inside the inner medulla it is going up, because urea cannot be transported in those parts of the tubule except the, again go back. So this is taking some time, just going back to the earlier slide, but this is what is very important. Urea is passively transported up to the thin ascending limb, but in the thick ascending limb, distal tubule or the first part of the collecting ducts, or you may say the cortical collecting tubule, urea transport is nil. So the urea concentration is rising along the tubule. Sodium chloride, but which is rising along the tubule, mostly urea, outer medulla, because urea transport from the thin descending limb up to at least the cortical part of collecting tubule, urea transport is not occurring at all. So concentration inside the tubule is rising. This is just to show. So countercurrent multiplier, Vasa Recta are the countercurrent this countercurrent exchanger. Sometimes, as this is an era where, as in say neuromuscular physiology, you get 1 or 2 questions, my clinical application of physiology, sometimes it comes, at least write what is diabetes insipidus. At least you should know that why the name has came. Insipid means tasteless, diabetes insipidus caused by deficiency of antidiuretic hormone. So the body is passing dilute urine. Body is passing dilute. That is diabetes insipidus. It is different from diabetes mellitus. So diabetes insipidus. Now this may be nephrogenic. This may be that you will study again in medicine. This may be central. If the pituitary is unable to secrete ADH, then it is central diabetes insipidus. If the pituitary is secreting, very simply stating, if the pituitary is secreting ADH, but receptors, ADH is, what are the receptors called? V2 receptors in the collecting duct or the later parts of the tubule, V2 receptors, if they are not working, then that is nephrogenic diabetes insipidus. And how that can be distinguished and all, that can again, if you are giving ADH from outside, still, just this I don't think will be asked in the first year. If you are say in some way giving ADH from outside, okay, but still there is no response, urine is not being able, the body is not able to form concentrated urine, that means it is the some problem at the level of the receptors, that is it is nephrogenic. But after giving ADH from outside, if the kidney responds, that means there is probably there is some problem in the pituitary, that means at the central level. That is how to distinguish between central and nephrogenic. Any hormonal or any disturbance can be, whether it is at the receptor level or it is the central level, can be distinguished by like this: injecting or the substance from outside. What substance is responsible? That is injecting from outside. Even after injecting from outside, if there is no response, that is the receptor level, there is problem. So whenever you get unknown questions also, try to tackle like this, try to apply your intellect. Although I think this will not be asked in the final, in the first prof, that how to distinguish between central and nephrogenic diabetes insipidus. It's just for your information. But in the medicine exam, when you get a explain why type of question, this can, or short question, you can get this. So this is central. There can be different causes. Primary tumors, don't concentrate on the causes right now. Nephrogenic, why it is occurring in the kidney due to obstruction or due to some drugs or primary kidney disease, whatever can happen. Nephrogenic is that issue at the level of the receptor level, that ADH is there in the body, pituitary is secreting enough amount of ADH or adequate amount of ADH, but it is not being able to act. That is nephrogenic diabetes insipidus. And primary polydipsia, that is called polydipsia, that is not being, that is formation of dilute urine. The person is drinking a lot of water due to unknown causes. It may be psychological or something. The ADH central part, pituitary is okay, kidney is okay. That means kidneys are responding to ADH, but the person due to some reason or the other drinking so much of water, that dilute urine is being passed. So treatment aimed at psychiatric disease, I think you don't need the treatment part. At least say water reabsorption along the tubules. A question comes and say one as a second part, 1 or 2 marks, at least what is diabetes insipidus. Okay, so you should be able to write what, at least what it is in your file. What is diabetes insipidus? So if we go to discuss, we can discuss a lot of things. Acid-base balance is left. I'll just go through. If this is see whatever how, if you don't, we just discussed tubular reabsorption last day. Whatever is this, if you can't remember the names of these channels or proteins also, sodium hydrogen exchanger, at least write antipode. Wherever it is antipode, opposite direction, write antipode. Wherever it is in the same direction, write sympode. Like we told, see, this is in the first part of the proximal tubule. This is glucose reabsorption. What was it telling? SGLT2. So that is sodium and glucose in the same direction. And GLUT2 through the basal membrane, apical membrane. Apical is towards the lumen and basal is towards the blood, where it will be reabsorbed into this blood. That is, in case of juxtamedullary nephron, it is Vasa Recta. In cortical nephrons, it is peritubular capillaries. Okay, reabsorption. So this is GLUT2. GLUT2 is this facilitate diffusion of glucose. So glucose transport, water transport, these are what are needed. This we have done. These things we have done. So just we are left with acid base balance. I think if you get a single day, it can be completed. But acid base balance, you read under the following headings. At least you have to that acid, either how does the kidneys maintain the acid base balance, 10 marks question was coming, that either most of the HCO3, most of the bicarbonate in physiological conditions, most of the bicarbonate, no bicarbonate is excreted. See, 99.9% of bicarbonate, that means almost, if filtered is whatever is filtered through the glomerular filtration, that means through the glomerular filtration, whatever is filtered, that means filtered load of bicarbonate almost more than 4000 milliequivalents per day. 4000 milliequivalents, it is 4320, 4000, and almost all of it is reabsorbed. So urine pH is acidic, urine pH, and maximum urine pH concentrating ability of, not concentrating, maximum or minimum pH that can be achieved is 4.4. So less than that it is not achieved. Less than that it is not achievable. So the body cannot. If there is much acid load in the body, the kidneys have a maximum efficiency, up to which the kidneys can help in excreting this acid. Okay. Another way of excreting this acid is, say, so this acidic, so CO2 wash out through respiratory. If it is acidosis is there, acidosis means acidosis in case of acid and alkali rising in the blood, it is usually not written as acidemia, although kalemia, rise of potassium. So rise of sodium is natremia, okay, hypernatremia, hyponatremia. So blood, sodium in the blood, natremia, potassium in the blood, kalemia. But usually instead of acidemia, the term acidosis is used, acidosis, alkalosis. So acidosis, one way of washing it is out is, this is through carbon dioxide, H2CO3 forms H2 and CO2, CO2 is washed out by breathing. If by hyperventilation, acidosis, but the kidneys, the renal mechanism, the kidneys can maximum limiting, it is called the limiting pH of urine, that is, the urine can be taken down, maximum pH, the maximum low pH that can be reached is 4.4, or it is better to say minimum pH that can be reached, because pH, lesser pH means more acidic, so the minimum pH that can be reached is 4.4, that is called the limiting pH through renal mechanism. So I'll just discuss the mechanism, how the renal, so read it under, you should read it under, I'll just mention how to read it. What is, just know these points, titratable acidity and what are the buffers present, okay, what are the buffers present, we will discuss them I think in the next class, but what are the buffers present? So all this we have discussed, we are going a bit haphazard because I thought I would get at least 5-6 classes for all these things, but nothing has been left out except acid-base balance. I think acid-base balance has been discussed to some extent in biochemistry, kidneys maintaining acid-base balance, but this comes as a question in physiology. If I get another class, I will surely discuss it in at least in short. All these things have been discussed, nothing has been left out, but if I would get 5-6 classes, I would discuss it in some further detail. Not much needed, I have not seen coming questions, how is the kidney maintaining potassium balance and all, these are not coming. Usually what comes is acid-base balance, countercurrent and tubular reabsorption. It may be tubular reabsorption as a whole or water separately, and from the anatomy part some few questions can come, or this GFR and all, glomerular filtration rate, what is it, normal values and all, and these factors affecting it. And also inulin is a good substance or ideal substance to measure GFR. Sometimes creatinine also comes. Creatinine is not as ideal as inulin, but creatinine is secreted in the tubules, but more or less it suffices. maybe 90% of the actual value it will give, but because 10% is secreted in the tubules, secreted. So what is the ideal? Inulin is ideal because it is neither reabsorbed nor secreted. It is not toxic, all those points are there. So that is one part, GFR. So these things, how is the kidney maintaining potassium balance? Usually I have not seen. We will discuss acid base balance as so. I will just tell you this. So how to distinguish between acidosis and alkalosis of different types in objective type of questions? If there is objective structured questions we are keeping in the exam, in the practical part of the exam, then this may help you to tackle. These will be problem based questions. So first you have to see in the, it will be given arterial blood sample, pH is this. So if pH is less than 7.4, it is acidosis. If pH is greater than 7.4, it is alkalosis. Now you have to find the cause. What happens is respiratory acidosis, PCO2, that means partial pressure of CO2 will be more. So in the values given, these values usually sometimes it is given in the question. So normal pH is 7.4, H plus is 40 milliequivalent per liter, PCO2 is 40 millimeter of mercury, and bicarbonate in plasma is 24 milliequivalent. Now if you see acidosis, if it is pH less than 7.4, if you see PCO2 is say 50, then it is respiratory acidosis, and you will see in the same, the bicarbonate value is given, it is say 30 milliequivalents per liter. That means the acidosis is due to acidosis, H plus increases due to increase in CO2. Body cannot wash out carbon dioxide, CO2 plus H2O, H2CO3, H plus H2O. So that is the cause of acidosis. So when carbon dioxide PCO2 will be more, it will be the cause of acidosis. If in the same question you see pH is say 6.8, 7.1, 7, whatever, and CO2 is more, HCO3 minus is also more. So due to increase in bicarbonate, acidosis cannot occur, alkalosis will occur. So this is why this bicarbonate is more, it is trying to compensate. Bicarbonate is more because relative to H plus, the body is trying to get rid of H plus, and as a result concentration of bicarbonate in blood rises. That is compensatory mechanism. So acidosis or alkalosis, there will be compensatory mechanisms. So not very difficult. If it is acidosis, if CO2 is more, bicarbonate is also more, then at least you can write it is respiratory acidosis. The bicarbonate part is trying to compensate. If the pH is 7.2, 7.1, then it is partially compensated respiratory acidosis, because HCO3 is just trying to compensate. HCO3 increase cannot be acidosis. Okay. Now if you find pH is say 7.6, 7.7, then it is alkalosis. Again think of the same situation, carbon dioxide is more, PCO2 is more, and bicarbonate is more. But as it is alkalosis, so HCO3 minus rise in HCO3 is the cause of the alkalosis. That is, it is metabolic alkalosis. That means whatever is occurring due to CO2, that means, or whatever is occurring due to CO2, that is respiratory cause of acidosis or alkalosis, whatever. Whatever is occurring due to HCO3 is metabolic cause. So first try to or first look at what is the pH given. If it is 7, this is acidosis. Now find the cause. If CO2 is acidosis means either CO2 is low, PCO2 is high, or HCO3 minus, that means plasma bicarbonate concentration is low. Acidosis, both will not be given. You will not both. So don't. So that is a silly question to ask. If both are the cause, no, both will not be given. If H plus is pH is more, either CO2 it will show a rise in the data will be there that CO2 has increased or bicarbonate is lower. So whatever you find, if bicarbonate is 16, so that is a cause, it is acidosis. Metabolic or respiratory, bicarbonate is 16, then it is metabolic because so although these figures, these standard figures which is the normal is given at, we should not at least actually we should not say 24, we should say 22 to 26. It is a range. It cannot be a single figure, as I have told through all of physiology. Nothing can be a single figure. It is a range. So it is 22 to 26. PCO2 is actually say I think 38 to 40 something. That is so H plus is also like that. pH is okay. pH we take 7.4. So if it is acidosis, first decide whether it is acidosis or alkalosis. Then in acidosis, if it is due to less HCO3 minus, that is less than 24, 16, 20, 17, whatever, it is metabolic acidosis, and at the same time CO2 can be low because it is trying to compensate. But CO2 low cannot be the cause of acidosis. Cause of acidosis can be CO2, high PCO2, but low PCO2 cannot be the cause of acidosis. Low PCO2 in acidosis means it is the compensatory mechanism. So it is respiratory compensation or renal compensation, that depends on the that inference comes from the compensatory mechanism, but never write when there is acidosis, PCO2 less cannot be the cause. So just think it out once more, then you can understand. I think you have understood, but if it is still প্রথমবার তো গুলিয়ে যেতে পারে। সো রেসপিরেটরি প্রথমে দেখবে পিএইচ কি দেওয়া আছে। অ্যাসিডোসিস হলে আইদার PCO2 লো, আইদার HCO3 মাইনাস লো অর PCO2 হাই। যদি উল্টোটা থাকে দ্যাট ইজ কম্পেনসেটরি মেকানিজম। আবার অ্যালকালোসিস যদি হয় তাহলে আইদার HCO3 মাইনাস, বাইকার্বনেট ইজ হাই সে 30, বাইকার্বনেট দেওয়া থাকলো 29, 30, তাহলে সেটা মেটাবলিক অ্যালকালোসিস। CO2 হাই হতে পারে, কিন্তু CO2 হাই গুলো তো আর অ্যালকালোসিস হবে না, দ্যাট ক্যানট বি দ্য কজ, দ্যাট হ্যাজ টু দ্য কম্পেনসেটরি চেঞ্জ। CO2 লো হয়ে যদি অ্যালকালোসিস হয় দ্যাট ইজ রেসপিরেটরি অ্যালকালোসিস। ওকে, সো হাউ টু ডিফারেন্সিয়েট বিটুইন অ্যালকালোসিস অ্যান্ড অ্যাসিডোসিস ইফ ডেটা আর গিভেন অ্যান্ড সিম্পল ডেটা উইল বি গিভেন, কনফিউজিং ডেটা দেওয়া থাকবে না, দ্যাট ইজ ফর শিওর। তারপরে কনফিউজিং ডেটা দেবে না যে এটাও CO2 ও বেশি, HCO3 মাইনাসও কম, এবার তুমি বলো কোন ধরনের অ্যাসিডোসিস, এটা হবে না। যদি CO2 এর জন্য হয়, CO2 এর জন্য দ্যাট ইজ রেসপিরেটরি অ্যাসিডোসিস, HCO3 মাইনাস বেশি দেওয়া থাকতে পারে, দ্যাট ইজ মেটাবলিক কম্পেনসেশন অফ রেসপিরেটরি অ্যাসিডোসিস। আর কম্পেনসেশন পার্টটা যদি নাও মানে সেটা নাও লিখতে দেওয়া থাকে হোয়াট ইজ ইউর ইনফারেন্স, কম্পেনসেশনটা না লিখতে পারলেও ফার্স্ট ইনফারেন্স ইজ অ্যাসিডোসিস অর অ্যালকালোসিস, তার জন্য পার্শিয়াল ক্রেডিট পাওয়া যাবে। যদি নম্বরের দিক দিয়ে ধরি 2 নম্বর আছে তাহলে 1 নম্বর ইট ইজ রেসপিরেটরি অ্যাসিড মেটাবলিক, সেটা ঠিক লিখলে 1.5। আর যদি কম্পেনসেশন কি কম্পেনসেশন হয়েছে সেটা লেখা যায় দেন ইট ইজ 2 আউট অফ 2, মার্কসের দিক দিয়ে বলছি, ক্রেডিটের দিক দিয়ে। কিন্তু অ্যাসিডোসিস বা অ্যালকালোসিস যদি ভুল হয়ে যায়, এবার অনেক সময় কি করছে অসপি বা যে পরীক্ষায় হচ্ছে ওর খাতায় কি লিখেছে, এবার অ্যাসিডোসিস মেটাবলিক পার্শিয়ালি কম্পেনসেটেড, এটা হয়তো উত্তর। এবার সে অ্যাসিডোসিস বা অ্যালকালোসিসটা ভুল লিখেছে, বাকিটা ঠিক টুকতে পেরেছে, তাহলে কিন্তু তার জন্য কোনো ক্রেডিট নেই। ফার্স্ট পয়েন্ট যেটা করতেই হবে সেটা হচ্ছে অ্যাসিডোসিস না অ্যালকালোসিস, ওইটা ঠিক লিখলে তবেই পার্শিয়াল মার্কিং আস্তে আস্তে পাওয়া যাচ্ছে। অ্যাসিডোসিস বা অ্যালকালোসিস ওটাই যদি উল্টো লেখা হয় তাহলে তার জন্য কোনো ক্রেডিট নেই।